Dear colleagues, ladies and gentlemen, welcome to the sixth session of TIO 2026, the global edition. And in this session, we will try to answer the question whether transcatheter technology can approach native valve physiology. With me here on the panel is Giuseppe Tarantini from Padova, Mohamed Abdel-Wahab from Leipzig, and Ole de Bakker from Copenhagen. And before we go to a recorded case demonstration from Rigshospitalet, I will start with a first presentation, basically the setup of where we are in contemporary TAVI, because the dynamics have been changing over time. So can I have the first slide up, please? And we will start with a changing reality in the United States. I think outside of the United States, it may be a little bit different, but over in the US, we see that patients under 70 years old, so just look at the left side of the panel. Most on the left side, you see how many patients under 65 years old with aortic stenosis are being treated with TAVR. Next to that is how many patients are being treated with SAVR. And then as you move up in the figure to the right, you will have the older patients. Well, forget about the right side of the panel. Let's focus on the left side. And you see that the number of patients every year is increasing. The number of patients under age 65 who are being treated with TAVR is increasing, and the number of patients under 65 years old who receive a surgical bioprosthesis is decreasing. And this is quite dramatic, because if you look at the blue pillars, then, and that represents the situation in 2023, then approximately 50% of patients under age 65 years old with severe aortic stenosis are being treated with TAVR in the United States already. So that is quite an important new finding and an important new reality. But that also may set the stage for a different dynamics, because we know that the life expectancy of a patient age 70 is approximately 15 years. At age 60, it's approximately 25 years. So that means that if a patient under 65 years old will get a TAVI, then there is a higher likelihood that this patient will require a re-intervention sometime down the road. And this is a calculation, an estimation that is illustrated here. So if you assume that a bioprosthesis will last 10 years, and if you get a TAVI at age 60, then you can imagine that at age 70, you will need a re-intervention, and you might need another re-intervention at age 80. Well, obviously, that comes with multiple consequences. And I already made an illustration of, by using simulations, what that could mean in terms of future prosthesis patient mismatch if you start adding up layers after layer after layer of stents. So I think this tells you that there might be better ways to improve the valve hemodynamics, especially if you look at more recent data from Partner 3 and Evolute Low Risk. Well, in Partner 3, TAVI and surgery were more or less on par in terms of valve, the need for re-interventions. But in the Evolute Low Risk, you saw that there was an incremental rate of re-interventions with an early generation Evolute valve. I think we have to take these data in perspective. We already discussed it during TIO 2026. But at the same time, we cannot say that this is good enough, because there may be better solutions. So what do we need for lifetime management? Well, we may need implants that are easier to implant, more reliable, more precise. We want to have low gradients and large effective orifice areas. And we want to preserve the physiological flow. And to this day, even surgical bioprostheses are not able to bring normal physiology back after the valve has been replaced. So we know that with a transition from a normal valve to aortic stenosis, you get all kinds of flow dynamics that change. You get vertical flow, you get acceleration of flow, but this is not completely restored with a surgical or a contemporary transcatheter valve prosthesis. So it's all about durability. And the question is, if we can come up with technology that will mimic native normal physiology, that might have an effect on durability. At the same time, you also want to preserve the coronaries, because up to 50% of patients with severe aortic stenosis unfortunately also have concomitant coronary artery disease, and younger patients may eventually down the road require interventions to their coronaries. And you want to also consider larger orifice area to increase the likelihood that you can re-implant, that you can do a re-TAVR, and maybe even a double redo TAVI intervention. So with that, I think we set the stage, and we can maybe first come with a case demonstration by Ole. So Ole, Giuseppe, and Mohamed. So what we're going to do is we're first going to start with a case demonstration of this biomimetic valve technology. This is a new concept of a balloon expandable valve that is currently the topic of a randomized controlled trial. And Ole had the privilege to do the first few cases in that randomized study. So Ole, the floor is to you.
Thank you, Nicolas. Indeed, I'm happy to present a DURA-VR case. We've done a few cases here now in Copenhagen in the early feasibility trial, also in the paradigm trial. So I want to share my experience in that. So as you correctly said, the unique aspect about this valve is really it's a single piece, native shape biomimetic design. So it's the real first TAVI device that really tries to mimic the coaptation also of the leaflets, the aortic valve leaflets, as we see it in a native anatomy. And so that's the unique aspect on it. On the other hand, it's also a balloon expandable valve. So this goes hand in hand with a very easy and precise deployment. We'll go to the next slide here. Here you see indeed the unique aspect of these leaflets. So you see the DURA-VR valve of Anteris Technologies in the middle. So with every systole, the leaflets really nicely go open. You have an extreme large effective orifice opening area. If you compare, for example, to the SAPIEN 3 23 millimeter on the left-hand side, you see that the commissures take a little bit more space and also limit the opening area there a little bit. And on the right-hand side, you see the typical opening of an Evolut Pro Plus valve, where you see kind of the fluttering of the leaflets. This is also something which does not happen in the DURA-VR. And as you saw in the previous slide, the DURA-VR leaflets have a nice, relatively long coaptation. So this should also hopefully be good for the leaflet stress. The stress on the leaflet should be minimal, and that should then result also in good and superior, hopefully, durability of this valve. So here you see the stand frame design as well, and also some words further on the leaflet. So it's a single piece, native shape biomimetic leaflet design. It's a bovine tissue with an LT calcification treatment. You see there a pad skirt on the outside to minimize the PVL, as we are used from most TAVI devices. It has a low frame height, as we are used to see in balloon expandable valves, with a nice open cell design on the top, which is of course favorable for coronary access. On top of that, we can implant this valve really reliably with commissural alignment. And then there's 3 valve sizes foreseen in the paradigm trial to cover annulus diameters of 21 to 29. So then this is the delivery system and the expandable sheet. So it comes with a 14 French expandable sheet, and it has an active steering mechanism. So you can navigate also torches, aortas, difficult aortic arches. That's all really nice to navigate through. You can also really reliably, which I will show in the recorded case, do reliable commissural alignment. So you can have an active rotation of the valve when the valve is actually already at position at the aortic annulus level. So it's not just a near commissural alignment. No, this is really, you can do a patient-specific accurate commissural alignment. And the good thing is also it's very easy. So it's a balloon expandable, and the valve is already loaded directly on the balloon. So you don't have to do a loading maneuver in the descending aorta. So it's directly crimped on the balloon, as said, 14 French expandable sheet, active steering. These are the steps a little bit. So we start out, you will see, before I start recording, we cross the arch in some LAO, coplanar view. When we cross with the valve through the leaflets of the native valve, we will check in the coplanar view the commissural alignment for the commissures. And then we will go to the right-left cusp overlap view. And in the right-left cusp overlap view, that's actually where I do the correction for the commissural alignment. We want 2 commissures on the left side, 1 commissure on the right side. And then again, you can adjust your height. Then it's a matter of finding the right height or depth of your implant, whether you do it in a tricuspid or cusp overlap. I think that's maybe not standardized yet also, but typically I look at both projections and I do my expansion deployment in my right-left cusp overlap view. The inflation volume is adjusted to the size of your patient, so it's volume adjusted, and then we do a final frame optimization with the double tap. That's something what we do standard. So here now this case. So this was I think this was number 1 or 2 in a paradigm trial, I think, an 81-year-old female patient, small patient, because currently we only have the small valve size, but very soon we will have the medium and large valve size as well. So this is a small lady, arterial hypertension, hypercholesterolemia, obesity, so no major comorbidities, and she's presenting with classical symptoms of a severe aortic valve stenosis. Then preserve the ejection fraction, high gradients. You see 67 mean gradients, normal ECG, sinusal rhythm, PR and QRS are normal. There's no relevant coronary artery disease on the cardiac CT, and then a very mildly reduced renal function. Here you see the annulus level, an area of 380 square millimeters, so area derived of 22 millimeters. And then also in the LVOT, very similar dimensions. There's no calcium, so that's very favorable. Sinus is spacious, so the small valve is typically, we call it a 24 millimeter valve, but to be honest, you adjust it, the size with the volume, so you cannot really call it a 24 millimeter valve, but just a small valve size, and then this you can bring it to 22, 23, 24, as you wish with the volume of inflation. So the sinus is definitely spacious enough. The ST junction as well, 29 by 30 or 31 here even. You see, of course, this patient had a really severe and high gradient stenosis. So this is moderate to severe leaflet calcification. And then the coronary height is 14 and 18.9, so no issues there. So these are the two views you use, a left cusp overlap view, which is very feasible, and a tricuspid view, also very feasible, LAO 16 caudal 8. Arch, nothing special, although there is some calcification in the arch, so that's nice that this system is kind of steerable and flexible, and then the axis is no issue. So then I go straight into the case. I think the procedural plan, transfemoral TAVI and local anesthesia is standard for us, pre-closure with a single pro style. We do some RV pacing, or you can also pace on the wire, of course. In this particular case, this is optional. We pre-dilated here because this was a high gradient stenosis with a mean gradient of close to 70 millimeter mercury. Limited experience with this device, so I think this may change in the future, but of course we went there for a safe approach of an 18 millimeter balloon pre-dilatation, and then the DuraVR small valve. So here you see this is this initial, so the expandable sheet is in place, 14 French expandable sheet, which you kind of pre-dilate with a bumper dilator or with a balloon, which you could do. This is the pre-dilatation, and here you see this is the valve which is crimped on the balloon, and this is the loaded part. So now we have to bring this into the expandable sheet. This is typically not an issue. You have to go in small steps that you don't kink this loaded part, but that's never really, never went wrong. Actually, it's a kind of small steps, very controlled introduction. You will see it now on the fluoro, also the valve soon coming out. I leave that loader in the sheet. I don't pull it back. And then here we come out with the valve. And as said, it's preloaded. What I also do, I take a small break in the descending aorta to see if the valve loading is completely correct. You see that triangle nose cone. So you don't want a too big gap, 1 or 2 millimeters maximally, and the valve should be really perfectly loaded. If not, then you have to, of course, not proceed. But here, we never had this. But here now you see here my colleague, he's actually turning on the steering wheel, we're flexing. You can really flex this delivery system 180 degrees. So typically what we want is we want to stay distal or below the pigtail, which is now it's a pigtail coming from the femoral. It's aligning nicely the outer curvature of the arch. You see these calcifications as well. So I think this is around, you see here on the window, it's around 60%, 60, 70% flexed. No issues crossing with this valve. We of course did a small pre-dilatation, but never really had an issue of crossing. So this goes all very controlled. And then at this particular moment, we took a little bit maybe of flex off here. Now we bring this kind of, we don't call it a pusher, but this we pull this system back to this radiopaque marker so that the balloon gets freed up when it's inflated. Now we check for the commissural alignment. So this is a right-left cusp overlap view. Maybe it's too detailed, but you see these small islets. You see these commissures. There's first some radius on the top, on the outflow part of the valve. We want to have two overlapping commissures. Yeah, here. You see these small black commissures with on the top these small openings, islets there. So we want two overlapping on the left-hand side as we have now and one isolated on the right. So this looks really perfect. Now, so this was with this distal wheel here. So now everything looks good. I went back to the tricuspid view to decide on my implantation depth. For this particular valve, I think we were kind of mid to upper, mid range of the size. So it depends for the positioning of your valve, whether you go with a marker on top of the annulus, at the level of the annulus, or just below, depending on whether you're on the lower, mid, or upper range of the sizing chart. And then this is, of course, simple balloon expandable positioning. So pacing on, positioning the valve with, as you see, this is the cusp overlap view, right-left cusp overlap view. You see the ascending and descending aorta overlapping, and then we inflate. Yes, and then what we do further is we do a double tap. So we position the marker here at the top of the first big diamond of, and then we repeat the fast pacing. And then we will inflate the balloon a second time. And we try to go up there to quite some atmospheres, actually a minimum of 8, 9, 10 atmospheres. And then we deflate again. So this can go very quick to really optimize the stent frame expansion. And then this is the final result. So you see a very nice high implant, 90% aortic, 10% below annulus, no leak, which we have seen in all the maybe 25, 30 cases we've done. We actually almost never saw a PVL, I think, as I remember. Pacemaker rate, I don't know, but I think from the small series that's been published, maybe I think Mohamed is going to show that it's around 10%. I think it's similar as we're used to in balloon expandable technology. So I think in summary, I think it's easy. Yes, it's first, it's an expandable sheet. It's a nice steerable delivery system, which gives you the option to steer, to do commissural alignment. The expansion and deployment of the valve is easy, as we are familiar with balloon expandable valves. And as you told us, indeed, Nicolas, we get the great haemodynamics for free with this balloon expandable valve, thanks to the great and optimized leaflet design. So also, we have used this in all this only small anatomy so far, and we never had any patient prosthesis mismatch case so far. So, but I think you will see more data on that.
Thank you very much, Ola. We have a tight schedule, but a question to Giuseppe. So, Giuseppe, if you would look into the future, what would be your preference, to have a tall frame or a short frame? Or let me reframe this. Do you think that we have unciphered the code for getting coronary access in patients who have received a tall frame device? Is it reliable enough?
Yeah, I think the point is always the lifetime management. So I think when you have a small annuli and a small ascending aorta, it's better to go with a short frame, because the neoskirt is always shorter compared to the tall frame in case of degeneration or restenosis. With this prosthesis, actually, I totally agree with Ole. This is not an exotic valve. Actually, we are very used with this kind of balloon expandable valve. There is a top row open cell and actually I think the coronary access is there. The point probably that I would like to ask to Ole is a little bit to know a little bit more about the height of these prostheses, the small versus medium size. What is your perspective when you think at the THV and THV, let's say, in case of need of reintervention, metrics and reintervention, Ole?
Yeah, so the height first, it's similar as a balloon expandable, as we know. Of course, there's slight differences, 2 millimeter difference, I think, in height. It also depends on your implantation depth, of course, but we like high implant to avoid pacemaker. But again, I mean, the beauty, if you talk about redo tough, I mean, if you assess a lot of CTs on this, typically the feasibility for redo tough, yes or no, is very, very much depending on whether your index TAVI, you got this one implanted with commissural alignment. If you did, typically you have a lot of options. It maybe involves leaflet modification, but almost all the cases that I've done or seen are doable. So I think, and then, so this valve has a low profile, maybe even if it's 1 or 2 millimeter higher than another more standard balloon expandable valve, let's by name Sapien. I don't think it makes a big difference, the 1 or 2 millimeters difference. The more important is that you can do commissural alignment. And then I think, I mean, I don't have the data, but I think 95 to 98% of cases should be redo TAVI should be feasible in these cases, where we use this valve, I think.
Yeah, so I think these are subtle tweaks to a familiar implant strategy, and I do believe, and I agree with you, Ole, that the fact that we are able to achieve commissural alignment also with these quote-unquote short frame devices probably can make a difference in terms of valve hemodynamics and valve durability. Okay, so let's move on then to the philosophy behind this biomimetic balloon expandable valve, the DuraVar. And we have a short presentation on that. So here are the slides. So what is this philosophy? Well, Ole already showed you and already mentioned that we're talking about a single piece biomimetic leaflet that is designed in a way that it is shaped according to the native valve contours. And the ambition is to restore physiologic flow and to minimize leaflet stress. And basically they achieve that with a different opening physics compared to other balloon expandable, or for that matter, self-expanding valves. And also, there is clearly a longer coaptation length. The coaptation length is up to 7 to 8 millimeters, which basically also aligns with normal anatomies. And it has less susceptibility to pinwheeling. Now, those are interesting features, but how does that translate towards flow? Well, here is some MRI study information where we compare the flow in a normal anatomy, a normal aortic valve, versus the flow in a stenotic aortic valve. And what you can appreciate clearly is that the color coding in the middle is different with a normal valve as compared to the stenotic valve. And that has to do, you see the bright red under and the more, the light red on top. And that has to do with the acceleration of flow as the blood is forced through a narrowing. And obviously, the aortic valve is a natural narrowing, but if it's stenosis, the narrowing increases, and so you have more flow acceleration, more energy loss, and pressure loss. Well, if the flow continues and if the blood flow further down the road, you have some pressure recovery. And we are very familiar with this phenomenon. It is also a hot topic in the context of echocardiography. But this translates, so you have this energy loss, and the energy loss can also be quantified. And that is what you can see on the far right panel, where the red color coding tells you where the energy loss is happening, loss of energy. And you don't see significant energy loss in a normal anatomy. You see clear energy loss in a patient with aortic stenosis, both at the level of the aortic valve, but also at the entrance of the aortic arch. Now, this translates into changing flow patterns. In a normal anatomy, you have laminar flow. You see that it's the straight line, whereas in a stenotic valve, you have these vortices and turbulence. And this turbulence is the result of pressure loss. energy loss and pressure loss. And this creates an afterload to the ventricle. So if we would be able to restore the flow on the right-hand side, which is a normal flow, versus the disturbed flow with the vortices, clearly visible on this hemodynamic flow computational CMR study, then you can understand that if you could normalize the flow back, so from left to right, well, that you might affect also the afterload that the heart is seeing. And this is exactly what we see here. So on the right-hand side, you see the flow in a patient after receiving this Duravar TAVI procedure. So basically, the flow has been restored, and this is what you not see in patients with valve replacement, either surgical or transcatheter valve replacement with contemporary devices. So in summary, TAVR has transformed treatment of aortic stenosis, and as we move forward and as we move toward lifetime valve therapy, the goal is no longer simply valve replacement. The goal is restoration of normal valve physiology. Why? Because with the restoration of normal valve physiology, you will reduce the afterload, and when we reduce the afterload, you also have more LV mass regression over time. And we already know from partner 3 data that LV mass regression, so reverse remodeling, is a good thing and prolongs and improves clinical outcome of our patients. So I think this is the philosophy of the valve, of the Duravar system. This biomimetic valve will restore turbulent flow to laminar flow. The laminar flow will decrease the afterload. Less afterload means better LV mass regression. All right, so that is the end of my piece. Giuseppe, maybe a quick question to you. Are you sensitive to this concept of afterload and afterload reduction with improved valve hemodynamics?
I think this is very important, this presentation, also for the people that attend, this meeting, because actually there is a shift of paradigm from gradients, I think, an effective orifice area towards a flow dynamics. But actually, I think I just want to make a comparison with the data that we have with the cord valve and the short frame sapien valve. When you look at the pressure recovery, it's much higher with the sapien valve compared to the tall frame valve. And this valve seems to be a kind of nice hybrid, because this is a short frame valve with the behavior in terms of flow, in terms of pressure recovery, like a supraannular valve, because the leaflets are not perfectly intraannular, but a little bit higher. So this is a very nice mix that try to take, the pro of the 2 different platforms, that is the short frame and the tall frame in terms of flow dynamics. So I think this is interesting to see if these flow parameters translate, but we need more data, into better clinical outcomes, or we are still at mechanistic stage. We need more data for that, but it's very promising to me.
I like your analogy to the hybrid between the contemporary short and tall frames, but we go really beyond that, because if you look at the MRI studies that João Cavalcante is doing in Minneapolis, he never has seen the restoration of laminar flow after transcatheter valve with short or contemporary tall frame devices. He has only seen it with this biomimetic valve. So I do agree with you. We need data to basically support these statements. But if we talk about data, there is already clinical data out there, and then Mohamed is going to give us an overview of that. Mohamed, the floor is yours.
Yeah, thanks, Nicolas. Yes, as you mentioned, we definitely need data on this platform, and there is some data available that I'm going to summarize here, which are mainly the 30-day outcomes in patients with small aortic annuli. So just this slide shows just an overview on the study program of the DURAVR THV platform. It started back in 2022 with a single-arm, single-center, first-in-human study called the EMBARK study that finished enrollment in 2025. This was followed by two small studies, one in the US and one in Europe. Like both were early feasibility studies with a small number of patients, and they finished enrollment in 2025. There is still a compassionate use program that has not been published yet in the valve-in-valve indication. And most importantly, there is the paradigm trial that Ole mentioned, which just started enrollment, which will be or is a big randomized trial comparing this platform with contemporary devices. So the data we have in the small annuli cohort are derived from the first three studies, from the EMBARK study, from the US early feasibility study, and from the European early feasibility study. You can see the numbers here. So overall 100 patients, and by design, and because, as Ole mentioned, the only size that is currently available and was available at that time is the small valve. These were like largely patients with small aortic annuli, defined, as you can see here, by valve area. These are the baseline characteristics of these 100 patients, and this has been published actually by Ole. So I actually presented the data that Ole has published. So he'll be probably more able to go into the much more details. But it's, as you can see here, typical TAVR population, when you're looking at small annuli, you find almost 80% of these patients are women. They were at intermediate risk, and there were some of them with bicuspid valves, around 9%, but otherwise a typical TAVR cohort with small aortic annuli. You can see here some numbers. So the average diameter was 22.7, and the average area was 404. Patients had the typical severe AS. The majority of procedures were performed, as Ole has shown, through the transfemoral route. A little bit more than half of the patients were pre-dilated, very little post-dilatation, but as Ole has showed you, this valve, or at least the protocol in these studies, requires a double tap. So almost like a routine second post-dilation. Very interesting here, the implantation time, despite the fact that this is a new platform, only 24 minutes, which shows you like the ease of use that we are expecting from a balloon expandable platform. And some challenging anatomies have been included as well. You see here some examples with patients with severe annular or LVOT calcium, some patients with severe leaflet calcification, as mentioned, 9% had bicuspids, with the overall very high technical and device success rate, despite the fact that these were like first in human and early feasibility studies. And the platform or the catheter required some adjustments in design during the course of these studies. Very encouraging 30-day outcome when it comes to heart clinical endpoints. So no cases of mortality at 30 days, 2% stroke rate. The pacemaker rate is actually only 6%, so a single-digit pacemaker rate, and otherwise very, very low complication rates. Maybe the most striking feature of this valve, as has been mentioned, is its ability to reach single-digit gradients, even in this challenging patient subset with small annuli. So a mean gradient of 8 at 30 days. There's a subgroup that has already 1-year data. It's a small subgroup of 37 patients. The gradients appear to be stable. And the orifice area, as you can see here, is above 2. No patients with more than mild paravalvular leakage, and strikingly extremely low rates of prosthesis patient mismatch. So only 3% overall that had moderate or severe PPM, and 97% had no significant PPM. So these are numbers that we are actually not used to in this patient population with small aortic annuli. Of course, when we look at the data of DURA-VR here on the right side and try to compare them with the data we have, for example, from the SMART trial, which is a randomized trial comparing SAPIEN and Evolut, despite the fact that it's, of course, scientifically not correct to match these data, but it could give us some interesting insights. So these are the numbers we know from the SMART trial for the balloon expandable valve, and we know from other clinical studies, usually a double-digit gradients in patients with small annuli, regardless of whether we consider gradients important or not, but this is how it is. So the gradients and the orifice areas are more or less comparable to those we know from the supraannular self-expanding valves. And the same similar observations when it comes to prosthesis-patient mismatch. Here are again the 3% observed in this study or in these studies, as opposed to 35% and 11% for the balloon and self-expanding valve in the SMART trial. So despite the fact that I mentioned that, of course, this is not a direct comparison and it's flawed by the fact that we are comparing apples and pears, but it's interesting because it could lead us to like a bit of rethinking of our understanding of hemodynamics, because we thought, regardless of flow, that gradients and valve areas are better with self-expanding supraannular valves and are less good with balloon expandable intraannular valves. So this is actually a valve that is intraannular and balloon expandable, but it has extremely good hemodynamics, very low gradients and high orifice areas, probably related to the leaflet design. So it's probably a bit beyond or a bit simplistic to think that gradients and orifice areas are only related to leaflet position. They are probably more related to leaflet design. So to summarize this, and as you've seen today, this is a biomimetic design trying to mimic performance of a healthy aortic valve, and it appears to have very favorable clinical outcomes, at least in these first 100 patients with small aortic annuli, with the very low pacemaker rate, as we might expect for a short frame valve, but more importantly, extremely favorable hemodynamics that we are not used to for short frame intraannular valves. And these findings will be evaluated in the mentioned paradigm trial, where Ola has already started enrolling. This is the big trial. More than 1,000 patients will be randomized to the DURA-VR platform or commercially available TAVI devices. A lot of sub-studies, importantly, some CT and MRI sub-studies, which will give us some mechanistic insights. If we find differences in clinical outcomes, patients will be followed up to 10 years. There's a dedicated nested cohort. It's like a single arm cohort for patients requiring valve-in-valve interventions. And there will be a continuous access, low-risk randomized cohort, only looking at patients who are at low risk for surgery, again, with a follow-up up to 10 years. So with that, I will give the word back to Nicolas.
Excellent overview of what we know already from a clinical point of view. Giuseppe, in your opinion, is it worthwhile to wait for the results of this randomized controlled paradigm trial, or should we have commercial availability of this technology earlier? What do you think?
I think that having more data and longer follow-up is always important. But actually, by this data, initial data, what I can say is that when you look also at the patient-prosthesis mismatch, it is a very important concept. I would like to get back to this point. When you make this comparison with the SMART, we need to acknowledge that this kind of measurement is non-invasive, and is in all cases a measured patient prosthesis mismatch. This is not a projected patient prosthesis mismatch. But these data are the proof of concept that because of the leaflet design, because of the length of the coaptation is longer with these leaflets compared to the intraannular valve. From the hemodynamic standpoint, this valve behave more like a supraannular valve. And this is very important because this means that you have less patient prosthesis mismatch, you have a better effective orifice area, but at the same time, considering that you can orient this valve, even though you stay very high with the implantation and you have a neoskir that might be 2 or 3 millimeter longer compared to the sapien, actually you can orientate the valve and this leaves open all the other options in younger patients that receive this valve. What I think is that this is very promising to implant in a very young patient. I think that we need more data, definitely.
You with the concept of restoration of laminar flow. I would like to thank Ole, Giuseppe, and Mohamed for their contribution to this compact session on the biomimetic TAVR. Thank you very much, and stay tuned for the next 2 sessions at TIO 2026. Bye-bye.